This recording will cover part 2 of seizures and epilepsy. So we're on now to talk about interventions for seizures, and we're going to start with drug therapy. Removing or treating underlying conditions or whatever's causing the seizure manages secondary epilepsy and seizures that are not considered epileptic. In most cases, primary epilepsy is successfully managed through drug therapy. Most seizures are completely or almost completely controlled through the administration of anti-epileptic drugs, also known as AEDs. So most of you are familiar with AEDs that are hanging on the walls in case somebody collapses and needs CPR and you might need to shock them. But if you see AEDs, you might also, and it doesn't seem to make sense, they could be talking about anti-epileptic drugs, also known as anticonvulsants. The healthcare provider introduces one anti-epileptic drug at a time to achieve control for the type of seizure that the patient has. We want to teach patients to follow up on lab test appointments to monitor the patient's CBC and liver enzymes and assess for therapeutic drug levels. Most AEDs can cause leukopenia and liver dysfunction. Teach the patient to observe for and report beginning gingival hyperplasia and perform frequent oral care to prevent permanent gingival damage. Do you remember which of these drugs listed was associated with gingival hyperplasia? It was phenytoin, one of the side effects of phenytoin. Teach patients to take their drugs on time and to maintain therapeutic blood levels and maximum effectiveness. Instruct patients that they can build up sensitivity to drugs as they age. Because of this potential for drug decline and sensitivity, patients need to keep their scheduled lab appointments to check serum drug levels. And you have here a list. These are all anticonvulsants. Your lorazepam and diazepam, those are your benzos that are used to treat status epilepticus. The others are more maintenance type medications, anticonvulsants. If they have a therapeutic serum value listed, you would want to know those also. And if you feel a little rusty, you can always review your pharmacology textbook. Watch for drug-to-drug and drug-food interactions. For example, phenytoin, if you remember, is highly protein-bound. So it shouldn't be given with warfarin. And if it is, you want to watch that INR very closely. Teach patients that some citrus fruits, such as grapefruit juice, can interfere with the metabolism of certain drugs. This interference can raise the blood level of the drug and cause the patient to develop drug toxicity. So if you're taking care of a patient with a history of seizures or they've been admitted with seizures, one of the orders for that patient might be seizure precautions. So what is included with seizure precautions? Precautions are taken to prevent the patient from injury if a seizure occurs. Specific seizure precautions do vary facility to facility, so you'll want to check your agency's policies. Seizure precautions include ensuring that oxygen and suction equipment with an airway are readily available. If the patient does not have IV access, insert a saline lock, especially if he or she is at significant risk for generalized tonic-clonic seizures. The saline lock provides ready access if IV drug therapy must be given to stop the seizure. And when you're working the floor, you also want to make sure that your rooms have the equipment you need, right? So maybe the previous patient had used the suction equipment and nobody replaced it. You need to be looking to make sure that your rooms are ready for that seizure patient before they get there. Side rails are rarely the source of significant injury, and the effectiveness of the use of padded side rails to maintain safety is debatable. Padded side rails may embarrass the patient and family, so you want to follow agency policy regarding whether side rail padding is used. Side rails will usually be up unless your facility policy tells you to do otherwise. Other methods could include putting a mattress on the floor instead of using side rails. Never use padded tongue blades, never have them at the bedside, and never put them in the patient's mouth. In the past, this was acceptable, so now there's a lot of education about no, don't do this. So if you think about why you wouldn't want to put a padded tongue blade into the patient's mouth, One, if it's back far enough, it could actually occlude the patient's airway. Also, it could chip off part of a tooth that could then be aspirated. The actions taken during a seizure should be appropriate for the type of seizure. For example, for a simple partial seizure, observe this patient and document the time that the seizure lasted. Redirect the patient's attention away from any activity that could cause injury. Turn the patient on their side during a generalized tonic-clonic or complex partial seizure because he or she may lose consciousness. If possible, turn the patient's head to the side to prevent aspiration and allow secretions to drain. It is not unusual for a patient to become cyanotic during a generalized tonic-clonic seizure. The cyanosis is generally self-limiting and no treatment is needed. Some healthcare providers prefer to give high-risk patients oxygen by nasal cannula or face masks during the postictal phase. For any type of seizure, you want to carefully observe the seizure and document assessment findings. When caring for the patient with tonic-clonic or complete partial seizure, we want to protect the patient from injury. We do not want to force anything into the patient's mouth if we're worried about them biting their tongue, because again, a patient biting their own tongue is better than having their airway occluded with a padded tongue blade. Turn the patient to the side to prevent aspiration and keep the airway clear. Loosen any restrictive clothing that the patient is wearing. Maintain the patient's airway and suction oral secretions as needed. Do not restrain or try to stop the patient's movement. You can guide movement if necessary to help keep them safe. Record the time the seizure begins and ends. At the completion of the seizure, take the patient's vitals, perform neural checks, keep the patient on his or her side, and allow the patient to rest. Seizures occurring in greater intensity, number, or length than a patient's usual seizures are considered acute. They may also appear in clusters that are different from the patient's typical seizure pattern. Treatment with a benzo, either lorazepam or diazepam, may be given to stop the clusters to prevent the development of status epilepticus. IV phenytoin may also be added. Status epilepticus is a medical emergency and is a prolonged seizure lasting longer than 5 minutes or repeated seizures over the course of 30 minutes. It is a potential complication for all types of seizures. Seizures lasting longer than 10 minutes can cause death. Common causes of status epilepticus include sudden withdrawal from anti-epileptic drugs, infection, acute alcohol or drug withdrawal, head trauma, cerebral edema, and metabolic disturbances. Status epilepticus must be treated promptly and aggressively. You want to ensure a patent airway and call rapid response. Establishing an airway is a priority for patient care. You want to administer oxygen as indicated by the patient's condition and know that intubation may be required. If not already in place, establishing IV access with a large bore catheter is very important. You can also start normal saline. Blood is drawn to determine ABG levels and to identify metabolic, toxic, or other causes of uncontrolled seizure. Brain damage and death may occur in the patient with tonic-clonic status epilepticus. Left untreated, metabolic changes result, including hypoxia, hypotension, hypoglycemia, cardiac dysrhythmias, and lactic metabolic acidosis. Further harm can occur as muscle breaks down and myoglobin accumulates in the kidneys, which can lead to renal failure and electrolyte imbalance. This is especially likely in the older adult. The drug of choice for treating status epilepticus are IV push benzos, either lorazepam or diazepam. But regardless, as long as you're recognizing it as a benzo ending in that PAM, you're good to go. So initially they're given that benzo to treat the status epilepticus, and then they're given a loading dose of IV phenytoin to try and get the patient to a therapeutic level of phenytoin again. Let's see. Phenytoin at no more than 50 milligrams per minute using an infusion pump. If we're piggybacking on an existing line, normal saline has to be what's priming the line. Phosphophenytoin is a phenytoin prodrug. It's compatible with most IV solutions, causes fewer cardiovascular complications than phenytoin, and can be given in an IV dextrose solution. Teach the patient that serum drug levels are checked every 6 to 12 hours after the loading dose and then 2 weeks after oral phenytoin has started. The desired serum therapeutic range is 10 to 20 micrograms per milliliter. Drug levels of more than 30 milligrams per milliliter are considered an indicator of drug toxicity. Patients who cannot be managed effectively with drug therapy may be candidates for surgery, including vagal nerve stimulation. Vagal nerve stimulation is just like it sounds. It's something that stimulates the vagus nerve. So what it is there's a stimulating device that's implanted into the chest wall with electrodes that are attached to the left vagus nerves. And they're constantly stimulating that vagus nerve, which helps prevent seizures. Also, the patient can activate the vagal nerve stimulator with a handheld magnet if they start experiencing an aura, and that would abort the seizure. When that's done, the patient will experience a change in voice quality, which signifies that the vagus nerve has been stimulated. Observe for complications after the procedure, such as hoarseness, which is the most common, coughing, dyspnea, neck pain, or dysphagia. Teach the patient to avoid MRIs, microwaves, shortwave radios, and ultrasound diathermy. A small percentage of patients with epilepsy cannot be controlled completely with drug therapy or vagal nerve stimulation. When all other options are exhausted, conventional surgery may be needed to improve the patient's quality of life. One type of surgery that can be completed is resective surgery, and that's the most common that we'll see with patients with epilepsy. And it's actually a removal of a small portion of the brain. So the part of the brain that isn't performing correctly is actually removed. The surgeon cuts out brain tissue in the areas of the brain where seizures are occurring, usually at the site of a tumor, brain injury, or malformation. Resective surgery is most often performed on one of the temporal lobes, an area that controls visual, memory, language, comprehension, and emotions. So there's obviously a lot of pre-testing done, and sometimes even during actual brain surgeries, they're going to be aware of what part of the brain they're working on, because they don't want to affect the patient's language, right? They only want to remove the smallest amount as possible to get these seizures to stop. I saw a video once of a woman who was a violinist, and during her brain surgery they woke her up to have her play the violin to make sure they weren't affecting the part of her brain that controlled that musical talent that she had. The corpus callosotomy is a surgery to completely or partially remove part of the brain that connects nerves on the right and left side of the brain. This is usually used in children who experience abnormal brain activity that spreads from one side of the brain to the other. So regardless if they're taking out a section or part of the brain, or if they're removing part of the brain that connects the right side to the left, what they're doing is interrupting the part of the brain that's having those abnormal neuron firing going off. And I'm going to let you look at the care coordination portion on your own.